Namaste and good afternoon. Respected teachers, revered alumni, dear friends, colleagues, and distinguished guests. On behalf of Department of Medicine, say GS Medical College and KM Hospital, I extend my heartfelt welcome to one and all present here. This is a Centenary Alumni Meet. This gathering is not merely an event. It's a homecoming of memories and minds. Ghar Vapsi in the truest sense. I am Dr. Smriti Tiwari, known by many here as Smriti Bajpai, and currently working as Associate Professor in Department of Medicine. And I'm privileged to be your Master of Ceremonies for today's event. नाम तो मेरा स्मृति है, पर आज के दिन की स्मृति आप सबके आने से है. Legacy survives only when leadership breathes life into it. Every department needs a leader, not a boss. Because boss says, do it, but leader says, let's do it. And it's my honor that I call upon a person who has handled residence, paperwork, patience, and peace, all with the same expression and poise. आमचे सर्वांचे आवडते HOD, Dr. Milind Natkar sir.
Namaskar. It's really a great day for me today to stand here in front of you as head of the department. We, the alumni of Department of Medicine at St. GS Medical College and KM Hospital, are celebrating today a century of excellence in medicine, a century of patient care, a century of commitment and cure, a century of shaping physicians, and century of research in medicine. I, Dr. Milind Natkar, stand in front of you in all humility as present head of the Department of Medicine to welcome all of you for this centenary function to commemorate the legacy of department of which all of us have been a part at some time, either as PG student or as faculty. So this department is as much yours as mine or as much as the current faculty and current residents. So this belongs to everyone. We are extremely fortunate today to have our Dean, Dr. Sangeeta Rawat Madam. But that introduction is secondary to me today about Dean, because she is also alumni of our department. And I think that is, I don't think every department is celebrating a centenary year this year. But I think ours is the only privileged department where the Dean, we can say that she's our alumni. So welcome, Madam, for this function and agreeing to inaugurate this function. I would like to welcome our academic dean, Dr. Harish Pathak sir. He is professor and head of Forensic Medicine Department, an extremely knowledgeable person. And if you start talking to him, he will tell you everything about mythology, apart from forensic medicine. I welcome our medical superintendent, Dr. Mohan Desai sir, who is professor and head of orthopedics and a big name in knee transplant surgery. I extend my great welcome to Dr. T.P. Medekar, sir. And when I welcome you, sir, I'm, when I welcome you, I'm welcoming all the faculty who has worked in the department in the past. You are the senior most representative of them, and we are happy to that you are come over here. Dr. Yavlekar sir is going to join in some time. He said that he'll reach by 3:15, so I hope he comes soon. I welcome my predecessor, previous head of the department, who is like my elder brother, Dr. Pazare sir. And I can only say that about sir, that sir, you retired, but every time that I enter my own office where you used to sit, I first see your image over there. So that close he is to me. I welcome all the past faculty and past PG students over there. And also I welcome all the present faculty and PG students in the department. For any medical institute, medicine department is always a prime and frontline department. Over the last 100 years, so many luminaries have headed this department, right from the first head of the department, Dr. M.D. Gilder. He was the first head of the department. To the last one was Dr. Pazari. And I think every HOD had their wisdom, good vision about the department and groomed the department. And I'm just carrying their legacy in the best possible way that I can do. Over the years, lot of new offshoots grew from our department in this institute, including Department of Cardiology, Neurology, Endocrinology, and so on. But I think still the leadership and importance of our department remains untouched. As we take all the patients with elements of all the systems. This was basically proved in COVID when we really managed with almost about 600 beds with 200 ICU beds, and we had 28,000 admissions during COVID, indoor admissions that we catered to. When we were to arrange this function, we had a big dilemma whether to hold it over here in the institute or go to a nearby 5-star hotel or some other hall or something like that. We debated a lot in the department, but we thought that the nostalgic feeling that one will get over here sitting in this MLT, the renewed MLT, I think that made our decision easy that, okay, we'll hold it here only rather than going to outside for some good extravagant food and drinks and all. We will have just over here only. Times change, and with times there are always new challenges that everyone faces. So is our department. We have to do a great balancing between patient care, research, and education with dwindling faculty. There is overall, with very regret I am saying that there is overall a decline in clinical skills because of various entrance exams for the future prospects. The cost of advanced diagnostics and newer treatments we cannot afford over here, so we cannot give that kind of treatment sometimes over here. There is always a patient overload, and there is always a deficit of ICU beds. There is a big problem of retention of skilled faculty and residents over here, but I am sure we will overcome all these problems in due course of time. At the end, I'll say that I hope you all have a pleasant, memorable time today. My department team has taken great efforts to put up this function, and I thank all of them for whatever they have done. And especially I would like to mention the great efforts put by Dr. Santosh Salagre and Dr. Smriti Bajpai, who are really coordinated each and every aspects of today's function, and I'm really very grateful to both of you. For any shortcomings, I apologize wholeheartedly, and I hope you enjoy this function today. Now I invite Dean Madam, our Academic Dean, Medical Superintendent, Dr. Pazhare Sir, Dr. Medekar Sir for the lighting of the lamp. Come.
The lighting of the lamp symbolizes the eternal continuity of knowledge, service, and wisdom. May this light guide us, our present, and illuminate our future.
सूर निरागस हो गणपति, सूर निरागस हो। शुभ नयना करुणामय गौरी हर श्री वरद विनायक। शुभ नयना करुणामय गौरी हर श्री वरद विनायक। ओंकार गणपति, ओंकार गणपति, अधिपति सुखपति छंदपति गंधपति, लीन निरंतर हो, लीन निरंतर हो। सूर निरागस हो।
मोरया गणपति बाप्पा मोरया, मोरया मोरया गणपति बाप्पा मोरया। गजवदना तू सुख करता, गजवदना तू दुख हरता, गजवदना मोरया मोरया, मोरया मोरया गणपति बाप्पा मोरया। गजवदना तू सुख करता, गजवदना तू दुख हरता, गजवदना मोरया मोरया।
ओ सूर निरागस हो, सूर निरागस हो। हो सुर सुमनाने भरली ओझळ, नित्य रीती वावी चरणावर। ताने बालक सुमधुर हासे, वावत से वाहो सुरातून। ओंकार गणपति, अधिपति सुखपति छंदपति गंधपति, अधिपति सुखपति छंदपति गंधपति, सुरपति निरंतर हो, लीन निरंतर हो। सूर निरागस हो, सूर निरागस हो, गणपति सूर निरागस हो। थैंक यू।
Thank you to both our talented interns, Advait and Drishti. Big round of applause, guys. we would like to honor the dignitaries with a floral bouquet, and I request our HOD sir, Dr. Nirin Natkar, to kindly do the honors. We begin with Dean Madam. Ma'am. I now request Anjali Rajyadhyaksha Madam to please honor our MS sir, our academic dean sir, Harish Pathak sir. No sir. I would request Salagre sir to honor our medical superintendent sir, Mohan Desai sir. I request Archana Sonavle Madam to kindly honor TPM sir. Woo! I request Professor Kavita Joshi Madam to honor our ex-HOD Pazare sir. We shall now witness the audiovisual presentation of our department's journey, highlighting the evolution of services, former and current faculty, leadership, and our collective vision for the future. इतिहास वो नहीं रचते जो शोर करते हैं, इतिहास वो रचते हैं जो कर्म करते हैं. And for 100 years, this department created history through quiet dedication and relentless service. May I request the technical team to kindly pay the Department of Medicine Centenary AV.
नगमे हैं, शिकवे हैं, किस्से हैं, बातें हैं. नगमे हैं, शिकवे हैं, किस्से हैं, बातें हैं. बातें भूल जाती है, यादें याद आती हैं. बातें भूल जाती है, यादें याद आती हैं. ये यादें किसी दिलो जानम के चले जाने के बाद आती हैं. यादें यादें यादें
हम रहे या ना रहे कल कल याद आएंगे ये पल पल ये है प्यार के पल चल आ मेरे संग चल चल सोचे क्या छोटी सी है जिंदगी कल मिल जाए तो होगी खुशनसीबी हम रहे या ना रहे याद आएंगे ये पल हम रहे या ना रहे कल कल याद आएंगे ये पल पल ये है प्यार के पल चल आ मेरे संग चल चल सोचे क्या छोटी सी है जिंदगी
I would like to thank Dr. Shraddha More, our assistant professor. Big round of applause. She has single-handedly made this AVs for us. I now have the honor of inviting a stalwart who is a true GSI through and through. a true blue blood GSite, as they say. She has completed all her education here, which means this institute didn't just shape her career, it practically raised her. Most of us graduate and leave. Some of us return to teach. But only legends like Dr. Sangeeta Rawat rise to become the dean of the very place where her journey as a professional began. एक बहुत ही हंसमुख व्यक्तित्व की धनी Dr. Sangeeta Rawat for you guys. Ma'am, may I kindly invite you to address us.
Good afternoon, all, and a warm welcome to the 100th year of St. GS Medical College and King Edward Memorial Hospital. My teachers, Dr. Medekar, Dr. Pazare, and my other colleagues, I really welcome. You must be really feeling that MLT has changed. Yes, that has definitely changed than what years of MLT we used to sit together here. And I really thank that you decided to have the function here so people could see the new MLT. So I think 100 years of our institute and our name of the institute is so tall all over the world. It's because of all the alumni of KM Hospital spread all over the world. So big hands to all of you. Everybody who has passed through the KM Hospital has become a GSite sometime or the other, has a different, different touch in their life, in their medicine, because you are a GSite. You have studied what our stalwarts and teachers have taught you from the bottom, how to see each and every sign, how to talk to the patient, and how to manage the patient to the best capacity. I think that knowledge and the skill which we get it as KMite, I think nowhere else we get it. And I've seen that like people who have gone abroad and said, also always say, no, we will send our children back here just to see how clinical material is just overflowing in KM Hospital. And I think that's where we become a good clinician because of the overwhelming trust which the patients have in our faculty. Every day today we have 6,000 patients as an OPD. We have 2,250 beds, and I still get a call for a ventilator and ICU every day. So when I took over as a dean, never in my dreams, sir, I had thought that I'll become a dean. I still remember the days where we were a medicine alumni. I and Hasmukh were in the Ward 9 together, where our love story started. So he was my 1 month locum registrar, because my actual registrar left for the US MLE and he went abroad. So I had no registrar. And I was happily doing my job. I said, registrar nahi hai, tension nahi hai. And one fine day, I came back after 10 days of leave, and I had a 2 days emergency, and the locum houseman had left. And then he comes and, tells me to do 3 cut downs and 2 LPs. I said, oh my God, where I've got this person? And, but then, after 5 o'clock when he came back, he said, I'll help you out. So that's where our story started. So I really thank the medicine department for giving my better half. And after that, I think when I finished my MD medicine, I joined with Dr. Medekar's unit as a lecturer. And then we realized that nahi, abhi dono MD medicine saath mein kya karenge aamne samne. So let's try the NEET. And then he got a neurology. And I said, tu kar le, mere ko to aise bhi nahi karna hai. I want to have raised child. Bahut ho gaya studies buddies. So like zindagi mein main kabhi neurology nahi kar sakta. So he decided to appear again, and then he made me also appear, because by the time I had also finished my MD, and then we both appeared together, and then he got in cardio and I got into neuro. So I think so I owe a lot to our medicine department, that our DM also came because we were together in medicine department. So to just, after that my journey continued, and so now few things which we did, which I took up as a dean and I did was, sir, you must see our new ICUs. Medical ICU and a stroke ICU we have renovated with Milind together, and it is really better than a corporate ICU. And we have got, I've started almost 7-8 new ICUs, which includes the neurology ICU, neurosurgery ICU, anesthesia ICU, orthopedic HDU, liver ICU, and a urology ICU. So all this I have done, but I still get phone calls for the ventilator and a bed because patients are overwhelmingly have faith in our faculty. So after that, we also have a 3 modular theaters now, ophthalmic, orthopedic, and we just recently did a cardiovascular. I think all of you, if you are a cardiologist or a CVTS person, please go and visit this. We have not announced it big way, but the CVTC OT has really come up excellently well, the modular theater. Today we inaugurated the Burns ward, which is done by CSR. So I really started the CSR in a big way because I thought there are people who want to go donate, and there are if you are ready to take it. So I think more than first year we got almost around 5.5 CR. Next year we got around 10.5 CR, and this year we are crossing almost 40 CR. So other thing which we did, tomorrow we are also inaugurating a sports center. We are planning to start MD in sports medicine, and that's the sports center done by BK Tires. And we have a 20 beds, 3 operation theaters, and a state-of-art rehab for the sports people. And I think that will be a big feather in cap for the KM hospital, because it's very, I think all over India, only 6 to 7 institutes have this sports medicine. We also have a knee joint robot. Dr. Desai has been operated more than 250 cases on knee joint robot, and no additional cost to the patient. Coming over to the new buildings which are coming up in KM, we have already next to UGPG Tower, we have a Centenary Tower 1 where the labs and the library will be shifted, and the library present area may be given up to the labs for the more expansion. Another which is coming up, it is an orthopedic building, a Karmachari Bhavan, where we'll have 2 wings. One will have almost 100 flats for the staff of the KM, and another will have almost 75 to 100 flats for the doctors of the KM. So I think what Milind was saying, that we have a lack of faculty. If you give home to stay, maybe they will come back and stay, because getting a residence in Bombay is really a big problem. Then our nursing quarters is already vacated, which is where we are going to have a 32-story building, which will have currently we have a GNM nursing, but we are starting, once we have that building, a BSc nursing will be started. And next to it, the AD bungalow and Dean bungalow are also unfortunately going to be broken. So in between the AD bungalow, in between the Dean bungalow, we are going to have a convention center. We'll have a big hall of 700 capacity, and smaller halls of 300 and 150. And we have a big foyer area for a pre-function, and good toilets and everything. So we might not have to go anytime in future to the 5 stars, and we'll be able to have all the conferences here. And where the Dean bungalow is, a new building will come where all the professors can stay, and the Dean will be, I think, on the top floor probably. Penthouse. So these are the few things, but here I was feeling always a pinch that we are not doing anything new for the patients. So the last, I think you all must have seen the curtain raiser program, which was a highly successful program, where DCM Shinde sir announced on the last day that he will definitely give us a 40-story building, where currently CO1, CO2 quarters are there, so that will be broken, and a new building will come where we'll have 5 floors of ICU, 5 floors of OT, and a CSSD, and state of art. Because of the heritage, many things we can't do. So if we have a new building, probably we will be able to do that. So please wish us all best of luck, so that we have this in the future, and our administrator agrees for that new building. Because often the arguments by MC and others was that there are so many new buildings which are coming up in the Shatabdi and MT Agarwal and everywhere. So they said, why in KM? I said, whatever you do there, but patients are going to come to KM. Patients want KM faculty and not the building. So I had tough time telling them, and I'm still not fully successful in telling that we must increase the capacity of KM hospital, because it is our centenary, and our league is always not for self but for all. And that's where I think if we have to serve the patients, we must have something additional coming up for the patients. So going on to for the students, definitely we have done a new gymnasium for the students. A new hostel is coming up of 1,200 students at Eckworth. And already one wing will be given in this December, I think within a couple of weeks. So henceforth, we will not have a problem of hostel in future. So that new hostel building will be an additional thing where, we used to till this year, we have written first MBBS, no hostel available. So I think next year onward, probably we will be able to change that. And so there are also, we have done, 100 साल हो गए, कुछ अच्छे कपड़े पहनाने चाहिए. तो मैंने थोड़ा beautification भी कर लिया है. Some LED panels, new fountains, one in front of, I think, gate 1, other at casualty. So where always the ambulances used to, stand and, very toxic atmosphere outside casualty. So I said, let us have some fountains and gardens. And we had planned that we will have a statue of Jivraj Mehta and Seth Govindas Sundardas over there. But somehow we haven't got the permission to do that. So we are planning that we will do it in our, inside the campus, inside the building somewhere, so that we don't have to go for this thing. But that's already the clay model is done, and now we just have to give the final. So we will have their statues also in KEM Hospital. So I think I have told lots of things which we're doing, but one more thing in the end is the LED panels which you see around, where we are playing patient educational films. So one donor has agreed to make 100 films with us, and each department is making 4 or 5 films with Whistling Woods, Subhash Gai, and I thank Shraddha, who has been a very active part of it. And those films are being shown on this film, on this LED screens. And it also has subtitles in Hindi. So even if they can't hear, they can see them and understand, read them. All the OPDs are having the TVs now, so where these films are being constantly played. And we are also having a QR codes of those relevant films in those OPDs where the patients can download in their mobile and take it to the other people, so where these films can be seen. So that is something which we have done for the patients. Nothing. Apart from the ICUs and these films, I hope I can do in future something more for the patients. And I once again thank all the alumni for coming here, spending your day here with your alma mater. And as Smriti said, कि Smriti, past की Smriti आपके पास वापस आ जाएगी. And you will remember your cutting chai of Milan and your nights at how you used to run around for the wards and how you used to fight in the going. नहीं आज 4 बज गए, आज मेरा call नहीं है, अभी कल का तुम्हारा call है. So I'm sure I still remember in Ward 9 when I used to do the emergency. what trolley का आवाज आया था, धड़ धड़ होता था. Oh God, one more patient. So those days I'm sure you will remember only when you go and see the ward. We have renovated 6 wards also. 6, all 4, 4A, Ward 12, Ward 6 and Ward 11, Ward 8. All 6 are renovated. So you must go and see them well illuminated. They are not that fancy, but they are well illuminated, nicely lit and with a good toilets and all those things. So all Ward 6 are also renovated. So we are trying our best. Okay, whatever renovation we do it at the corporate level, and we are nowhere less than this. So even this MLT hall, which we just renovated. And I'm planning that medical seminar hall also will be of the good stage. Today only I asked them. So he has promised me in next 1 month he's going to give you the medical seminar hall. So thank you once again for coming and gracing this occasion and joining us for the 100th year of our Seth GS Medical College in KEM Hospital. Thank you.
Thank you, ma'am. And I must say that our dean is so with the times that you can now catch up us on Insta, Facebook, YouTube.
So that's another thing which I did. I started the social media for KEM Hospital. अरे बुरा बताने को तो सब रिपोर्टर है, हमारा अच्छा कौन बताएगा? So we have 8,000 followers on Instagram now. And we have more than 3,500 subscribers on the YouTube. So I think the social media is the way out for the younger generation. And now हमको बताना नहीं पड़ता हमने क्या किया. We just put it on Instagram. They call up, madam ये news करना है, किससे मिले? So I think that you need to move forward with the younger generation. And I have learned Instagram after becoming the dean, not before that. And Shraddha is a big supporter for that.
Ma'am, I would request our HOD sir to please thank Madam with a small token of our appreciation. Yes. Can we see? Woo! Ladies and gentlemen, we now proceed to the keynote address. It's an absolute honor to welcome a man whose name has become synonymous with excellence, precision, and unwavering dedication, Dr. Yash Lokhandwala. His work, his vision, and his compassion have created ripples far beyond the walls of this institute. His legacy is not measured in years or titles, but in the lives he has transformed and the values he continues to embody. Sir, the stage is all yours.
Thank you. Yeah, Sangeeta, it was really a great thing to come in this MLT. Last time I came a year ago, I think it was different. And I went even to the washroom and I was amazed. It looked like the Mumbai airport washroom. So it's really amazing. I remember the MLT for three things. Of course, academics, debates, and cultural program, the orgy. And last is all the fiery meetings during the MARD strikes. So without wasting any time, let me move to this topic, which is this one. So I've decided to speak on research, but I'll try to keep it in relation with the people which I will be showing, who are all alumni of the Department of Medicine or the Department of Cardiology. My teacher in medicine was Dr. Vidya Acharya, whose photo you saw. But I must, along with Dr. Medekar, not forget stalwarts like Dr. Anjarya, under whom I was registered for MD Medicine, and so many other role models like Dr. Sunil Pandya, who passed away recently, and so many teachers from MBBS days, Dr. Dharani, Dr. Kendulkar. It will be, I'm sure I will not be able to finish naming all the people. And more than anything, more than the teachers also, it was the students around us, people who were 1 year senior, 1 year junior. And the culture in KM was, I remember sitting outside on the katta here outside the dean's office and having clinics where, Bharat Dalvi would be teaching us Witzel Schulz, I remember, clown of the ward in liver cell failure. Okay, so the topic I've selected is, once we go out in clinical practice, it's almost very few people who really manage to do some research for various reasons. And therefore, I selected this topic as to, first of all, why should we do it at all? And secondly, if we want to do it also, how can we do it? So I did some research on the origin of the word research. And it means actually to look at something very, very closely. And it comes from medieval French. And the only opportunity we had for research was our thesis. I remember my MD thesis was on pseudomembranous colitis. And the nephrology department had wonderful record keeping. And Dr. Acharya was a taskmaster. Alan is here. And I did that. But somehow translating that into a publication was never sort of ingrained into us. Unfortunately, what I'm seeing is that many theses, people say, okay, this is what topic will you take, do something, find out something, and they'll say, I'll do this because it's never been done in India. That means something which someone has done, you want to research that. On the other hand, if you give a novel topic, like I gave a DNV thesis to one of my students and said, this looks good, the diastolic function during atrial fibrillation, after 1 week I was told there are no references, how can I do this? I said, that's the whole idea of research. Do something that doesn't exist. Now the question is, if we really reflect, how many of us feel that yes, we want to do some research. We are not talking of basic research, molecular research, but clinical research, but I don't have the time. Or we don't have the facilities. How can you do research with the meager facilities that we have, especially in clinical practice outside of academic institutes? So this talk will walk us through why we need to keep doing some sort of introspection and research, and what avenues exist for clinicians with limited resources, and finally, how can this translate also into something which benefits the community? Uday Bhaskar Khanolkar was one of the people who first published, I published a paper with him. He had a booming voice and he was doing cardiology when I was doing medicine. I was registrar in Ward 9 and he was living on 5th floor of the new RMO quarters. And when he used to speak loudly, we could hear him in Ward 9. So therefore I said, I must acknowledge he couldn't come today, but he's in Bangalore now. And then actually my first real introduction to doing some meaningful research was by none other than Bharat Vinayak Dalvi, in those days having 300 ka kimam. And he actually told me that you've done balloon mitral valvotomy 100. What have you learned that your 100th is different from the first one? Unless you analyze what you've done, you may not publish it, but you analyze it. Doing 100 is like doing one procedure 100 times. You're no better. Then in 94, I had gone to Holland for a year for electrophysiology training. And Dr. Hima Kulkarni had the vision, who was the head of department, to allow different people to develop different specialities rather than everybody doing the same thing. And the person I trained under was Professor Hein Wellens, who in this very MLT had a wonderful talk on the ECG in emergency decision making. Unfortunately, he's no more, and this is him in the CBTC auditorium on the 3rd floor. You can see he's taken out his suit because I think it was a bit too warm for him. And then when I was in Holland in 95, I told him, I want to publish some paper. I want to do some research. Because they used to do a lot of work in electrophysiology. I sort of collect 100 cases and analyze. He said, okay, you want to do something, but what is your question? And I was dumbfounded. Because that concept of raising a question which you want to answer, the concept of research was, chalo, collect cases. So many we did, so many, this happened, that happened. But what's the question in your mind? And therefore, every research to start with a good question. See, now many times it is compulsory to publish papers to get promotions. So people say, okay, for that we'll do research. But if it's not mandatory, why on earth, why the hell should I do any research? I'm already busy as it is. First thing is, when you even write a case report, you realize there are so many lacunae about that aspect of that disease that you didn't know. So when you write an article, you actually learn. And more than that, nowadays there's a profusion of journals. You pay money, you get articles published. But if you want a good index journal to accept your article, you'll realize that that article or a case series or a case report is filling some lacuna. And that is why the journal is accepting it. So you're adding something to the scientific knowledge. For an institute like KEM, for sure, the ranking of the institute, whether today you're in a public institute or even private institutes which are teaching, the institute benefits in terms of its ranking. The residents, the junior lecturers, they don't realize it that time. But later, after they pass out and they then decide, now what do I do? Okay, I want to apply for a fellowship either here or abroad. What publications you have make a lot of difference. And if you keep having this introspection, analytical mind, and over a period of time, see, today we are flooded. We are flooded with this guideline, this advice, the pharma industry, the device industry. And let me tell you, very often even bodies like, which we many times in lectures people parrot, the American Heart Association says so and so. So what? So what? You know, there has been this thing that most of the people who write guidelines are paid $30,000 to $500,000 a year from the industry. So over a period of time, if you yourself are analyzing, then your thought process starts getting critical. You will not accept anything new. Like Professor Wellens used to tell me, one study is no study. You know, unless it appeals to your logic and unless it has scientific exactness. So therefore, analyzing an article, having journal clubs, and writing an article on your own is actually helping you in the long run. Internationally, or even nationally, you will be known today more by what you have published and how many people read it and how many people quote your article. And finally, even in practice today, in this world, if you want to practice ethically, many times the patients who are referred to you, I have at least thought, a large chunk of them when I started practice for my students. So your colleagues, your students will refer at least those things to you which you publish. So research is not just large trials, not just large trials. It can be, and I'll show you some examples, it can be simple things. It can be an interesting image. It can be a small case series. More important, we should develop our own registries, which I'm sure now more and more people are doing, rather than relying on data from other countries. And be part of some making guidelines ourselves. How do we know, and this Dr. Avinash Supe had taken a beautiful lecture, if your research is a good one, if what you're planning, it has a finer criteria. First, it should be feasible. Take up a thesis which you can do with your existing facilities. It should be interesting, something new, something that's not been done before. It has to be ethical, obviously, and most important, it has to be relevant. It has to be relevant. It has to be something that can be translated into day-to-day practice. Why are the guidelines from developed countries, whether it be Western or even Far Eastern, not really applicable many times? And I'm taking cardiology examples because our patients are younger. For example, myocardial infarction we get at 10 years lower age. Sudden deaths occur at lower age. Rheumatic heart disease is still a problem. We have different types of infectious diseases, myocarditis, etc. Then therapeutic modalities have to be totally different. We cannot talk about implanting ICDs in everybody with a poor left ventricle. And it's not necessarily the right thing to do anyway. Even rich countries are now having introspection about what they have been doing all these years. So therefore, I now come to my juniors and colleagues. Amit Vora, who is sitting here in the audience, did the first randomized study in which I was a part of. It was called the CRAFT trial. And that was done in KEM. And in fact, it has a lot of citations which showed that in rheumatic heart disease, you don't have to just accept atrial fibrillation. Most of these patients can be brought back to sinus rhythm. And this was a landmark paper. And so it's feasible. It's feasible to do randomized studies even with uneducated patients. If you explain to them properly, they will be willing for randomization. Then we have these cardiomyopathies who come with ventricular arrhythmias, atrial fibrillation. We never knew the etiology. Just like Sen and Kinare described tuberculosis as the middle aortic syndrome, as an Indian variant of aortoarthritis many years ago. Similarly, we found for ventricular arrhythmias, many times you get myocarditis with lymph nodes, which have granulomas. Either they are tuberculous, or they are sarcoid, or they are undetermined, or we call them sarco-TB, for want of a better term at present. So this we've been seeing them from the time we were in KEM cardiology, but we collected all these data with 20 years follow-up and published it 3 years ago. At Sion Hospital, where I now visit, with a lot of, the pediatric department is very active. There's a lot of children with myocarditis, and many times they have arrhythmias. And the spectrum of arrhythmias that we found in those children were quite different from what is described in children with myocarditis, let's say in Japan or in Australia or in other countries. So as I said, our problems are solutions. Now, mitral stenosis, it was sad that people used to die of mitral stenosis, and they used to come at a very advanced age, especially women, because they used to keep their symptoms to themselves and come sometimes in cardiogenic shock for the first time. And they would die. We used to call the surgeons. I remember surgeons at the bedside in the ICU doing surgery, and a stray patient would survive. So we then decided when balloon valvotomy came that let us take these patients, at least try to save them. And this was one of the top journals in the world, the Journal of American College of Cardiology, and it was a DM thesis of Darshan Banker. And Bharat Dalvi was one of those who really helped put this data together. So what we showed was that 65% of patients could survive if you did this. And I think this article has been quoted a lot of times. We all know what barriers we have. We have limited funding, but let me tell you, if you really write a good research proposal, the ICMR and the Department of Science and Technology have unused funds every year because there are not enough proposals. But of course, we don't have full-time research coordinators, especially in the private hospitals. And in the public hospitals, there's too heavy a clinical workload. So there are constraints, but despite this, a lot can be done. Ajay Naik was one of our other medicine department alumni who first, and we used to have this constant interaction with Dr. Kinare in the pathology department. And then in the autopsy also, we used to always see, for example, I'll come to that, but you see myocardial infarction, a lot of hemorrhage, and we wondered this is not described. And then Ajay published that streptokinase, we always thought that it's dangerous for the brain in stroke because brain is a soft organ, heart is a compact tissue, but some people with myocardial infarction do develop myocardial hemorrhage with streptokinase. In fact, whenever I used to say autopsy here, which we were compelled to as students to go, I always saw black lungs. I never saw pink lungs. I always thought lungs are supposed to be pink. I don't know if anybody of you has seen an autopsy in KEM where the lungs were pink. And then once when I went to Vellore, I found that the lungs were, I said, let me go and see. And they were much less black. But nobody ever did research. Actually, I don't know, what we are breathing day in and day out, I don't think any of us, when we die, will have pink lungs. Electrophysiology was totally new when I came back. Ablations had just come back. KEM was the only hospital probably in India which was doing them in an organized manner. Amit, Ashish, you all would remember, we used to start at 5 p.m., go on till 10. There would be a couple of months waiting list, and patients from all the way from Kashmir down to Chennai, down to Assam would come to KEM. So at that time, whatever we published was new because it was a new field. And Santosh Kauthale was the author, probably the only person from Latur at that time who got an article in the Journal of Cardiovascular Electrophysiology, which was one of the top journals of the world, where we described that ventricular tachycardias in normal hearts can have multiple morphologies. Another DM thesis, Satish told, again who did DM with us, who's now professor and head of department in Canada. We used to give adenosine, at that time an expensive drug, and some of our registrars used to manage to stock in their locker. And we used to give adenosine in sinus rhythm to try to make out what SVT this patient actually has. So patient with SVT would come in sinus rhythm, and we would give adenosine in sinus rhythm. And this original research was a British Heart Journal which became Heart. And this also has a lot of citations. And we found that the positive predictive value was 96%. So it was quite a useful test. And even now, sometimes they do it when patients come in sinus rhythm. I can see Bhavesh smiling there because second author there, I really had to goad him to write papers. The other thing we learned was that you must go interdisciplinary. For example, radio frequency ablation first came with the neurologist with trigeminal neuralgia. Then came to the cardiologist for arrhythmias. Then went to the interventional radiologist for all sorts of tumors. Then went to the gynecologist for endometriosis. So interdisciplinary, you learn a lot of things. And this was many years ago. Anup Gupta, who's now in Ahmedabad, along with Vineta Salvi and the gynec department, in those times, you can see within 2 years, we had 40 pregnant women undergoing balloon mitral valvotomy. So again, this used to be a problem, you know. First time realized you have mitral stenosis in pregnancy. And we showed a good outcome. And this was again one of the very premier journals which has a lot of quotations. Second thing that research helps us is develop collaborations with other institutes in other parts of the country and abroad. For example, this was many years ago, people with refractory ventricular arrhythmias. You've tried everything, no arrhythmic works, bypass, angioplasty done, ablation tried, then we sympathectomy, removing the sympathetic nerves, and in fact, Dr. Jignesh Gandhi from KEM actually does quite a few of these for us videoscopically. So this was published in the top journal at that time, Circulation, and it now is recognized as one of the accepted modalities in selected patients. Dr. Robert Anderson is a world authority on cardiac anatomy. In fact, he has come to KEM here also many, many years ago, in the times of Dr. KG Nair, I think, and had debates on cardiac anatomy. So we had these atrial arrhythmias which behaved like AV nodal arrhythmias. And therefore, when we published this paper, Professor Anderson was one of the authors who showed that actually, in addition to the normal AV node, there is also embryologically another AV node behind the aorta, which is near the atrium. And possibly these atrial tachycardias have something to do with the retroaortic node. Peter Schwartz is numero uno in long QT syndrome. Anywhere you open long QT syndrome, you see Peter Schwartz. And along with Dilip Karnad, we had this collaborative study, because how to measure QT interval? Often pediatricians will send you ECG, QT is prolonged, but actually it's normal because they have fast heart rate. So everyone said Bazet formula is useless, which is the commonest QT by square root of RR. So we did this study with Peter Schwartz in thousands of pediatric ECGs and came to the conclusion that no, Bazet's formula is still the best for children. So for research, important thing is ask a simple question. See that the question can be answered with your existing facilities, and see that it's relevant to applying to clinical practice. This was one of our recent papers, diastole. What is the duration of diastole? 2/3 of the cardiac cycle. Everybody goes from my first day of MLT, 2/3 of the cardiac cycle. Then when we used to do this resynchronization for heart failure, I saw that patient has improved so much, but we are never 2/3 of the cardiac cycle. Sometimes we are not even 50% of the cardiac cycle. So that led me thinking, is diastole really 2/3 of the cardiac cycle? So now with echo, with modern echo technology, it's very easy because you get the valve opening and closure sounds. So exactly what is systole and diastole you can measure. Otherwise, you have the classical Wiggers diagram, which was based on study 50 years ago. Well done at that time, but with those facilities. And actually, I searched literature for 1-2 years, and nobody has bothered to find out what is diastole, because it's accepted as a gospel truth. And what we found from this study was that it is actually 58% of the cardiac cycle. Now you may say, what is 58% and 66%? Well, this is basic teaching in physiology. You cannot tamper with basic truths. It also matters when you program heart valves, when you manufacture heart valves, intra-aortic balloon pumps, so many other things. So ours was a pilot study. Hopefully more people will do later to find out, but it is definitely not 2/3 of the cardiac cycle. In COVID, just like others, we had some guidelines put together by some of our colleagues from the south, Nambudiri, especially from Sri Chitra, about what we should do, which was socially relevant. So consensus statements, I think be part of these consensus statements and contribute to them. Every time we were reusing and then suddenly government mandates would come, you cannot reuse. But where do these people go? If you get machines of 3 lakhs and 4 lakhs, you are not giving, you are saying don't reuse. There are good machines with good life lying around. Patient is willing, but you are not allowing. So to give it legal sanctity, and these are all, most of these are KEM alumni. Behzad Pavri, 1 year junior to me. Bharat Kantharia, 3 years senior to me. And Neville Mascarenhas, Dr. Medekar will remember, Alan will remember, who still sends all these donated devices. So there's a good journal called Annals of Internal Medicine, which said that reused devices are no inferior to new devices. There's no increased chance of infection provided you take adequate care. We are flooded today with health checkups. When I go to some of the corporate hospitals, I see people going around with different color labels. You know, some are with golden, I'm gold checkup, executive checkup, super this checkup. They remind me of the cattle which I used to see in Holland. Because when the cow was born, they used to have a label. The date of their slaughter was decided on the day of their birth. They used to have labels. And I used to say, these are cattle to the slaughter going to these multiple tests, unnecessary tests, copper, etc., etc. So really with the medical students, we did this routine health check. In fact, you will be surprised that insurances in most developed countries do not reimburse routine blanket health checks because it does not prolong the life of the population. You have to do targeted health checks, and this was put together in National Medical Journal of India. Finally, some TV program also took it up, but finally nothing has happened. They are just booming by the day, health checks. So finally, to conclude, I'll come to cardiac arrest, which in the last decade has become very close to me, to my heart. Hopefully I'll not get a cardiac arrest soon. But every year about 15 lakh Indians die suddenly. 80% of them die outside hospital, at home in the market, etc. We know the survival rate in the community of cardiac arrest in India is less than 1%. In certain cities of the world, it is the best cities, like Seattle or erstwhile Moscow or Scandinavia or Japan, it is up to 50%. We are less than 1%. So we said in 2017, 3 of our colleagues in their 40s, including one from our department, Dr. Prasanna, died, had sudden cardiac death. And we said, let's do something. Because government has many more priorities, let's do something. And we started this cardiac arrest resuscitation for everyone, iCare, called Revive Heart Foundation, with some meager grants and Holy Family Hospital giving the place and some dedicated doctors giving their services. Important thing is, who can save you in a cardiac arrest? A bystander, not a doctor, not a paramedic. Unfortunately, in our training, we that time didn't have formal training of even how to recognize cardiac arrest. For example, you don't have to recognize cardiac arrest by the pulse or by the carotid. And that I learned when I started doing this. It's by lack of breathing. Because if you start teaching bystanders to teach pulse, there'll be a lot of wrong diagnosis. So it's by absence of breathing. So we started this, and it's built up, and we had colleagues in other parts, the Anesthesia Association, there is a resuscitation. We realized there are many people working here and there, so we brought everybody together and have these cardiac arrest weeks, awareness weeks, and KEM has been a big part of it, especially the anesthesia department here. So the Revive Heart Foundation in the last 8 years has trained about 4 lakh odd people. But importantly, this includes the police, the railways, and other government institutions. And our colleagues in other parts of the country also are doing this. Hopefully we will reach in a few years a critical mass. Already it has started coming in some of the educational syllabi and put some pressure. And actually these are people who have been saved in the community, either trained by us or by our colleagues. So it's possible. It's possible. In fact, Premnath was the architect who had designed the Nehru Planetarium. And these efforts were also recognized. So now there is, by journals like the Lancet, the highlighted one mentions the Eye Care Revive Heart Foundation and its work in India. And so does this recent article, which is just soon going to be published in the Indian Pacing and Electrophysiology Journal, talking about the efforts of the organization. So point is, social research is probably the most rewarding. So there are many types of, and we didn't do this as part of a research, but some initiative which you take can also be translated into a scientific paper. There will be nothing without AI in future. Whether you believe it, don't believe it, like it or hate it, but you can't ignore it. So therefore, all of us will have to get familiar with AI, its usefulness as well as its limitations. I'll finally end with one of the former chairs from the Harvard Medical School, who said that the teaching hospital actually links research to teaching and to service. And globally, that is what is most missing. Thank you.
Thank you, sir. Deeply insightful, motivating. As sir said, it's not the resources which limit. It has to be the insight, the intent. So aptly said, sir. I would now request our HOD, sir, Dr. Milind Natkar, to felicitate Dr. Yash Lokhandwala, sir, with our Indian tradition of Shreefal and shawl as a token of our gratitude and respect, sir. So we now move to the most revered segment of the evening, Pearls of Wisdom. Where the stalwarts speak. Trust me, we are very lucky and honored that our department is full of such personalities, that it was so difficult to choose one among so many. But as they say, हम medicine वाले बहुत gutsy होते हैं. And we have been able to narrow 5 such eminent personalities who I would be calling upon the stage, and I'm sure they would stick to time because we are already late. I began by calling upon our Pitama. And the Pitama of a medicine family, as he is one of the most senior-most person amongst us today. And I'm sure you must have recognized it's none other than Dr. Yolekar, sir.
Good afternoon, everybody. Extremely happy and glad to see so many faces on this important occasion of medicine department. Oh, so many faces, familiar, smiling. And during the centenary year. Now what Smriti told me, sir, you have to speak within 3 to 5 minutes. And you have to deliver pearls of wisdom. I must tell you one thing, that medicine always has been a branch of sharp minds. So mind, intellect, and followed by wisdom. Wisdom, of course, in Indian tradition, person like me who has crossed 75 is expected to impart some wisdom. But now the times and days are such, day-to-day experience in our clinical life, happenings around, the life itself makes you sufficiently wise. But all said and done, a couple of things I must tell you, which of course I am telling to my son. He is now 40 plus, and he is a practicing ENT surgeon and rhinoplasty specialist and what not. But I tell him, because he is always busy and difficult to get a time for a dialogue with your own son can be a very heartful affair. But one thing is very clear. I told him, success without all-time stress. That is the thing of medical profession. Constantly we are in our, and now one of the factors in relation to cardiovascular health is related to continuous related release of catecholamines and cortisol, what is termed as allostatic index. Higher the allostatic index, the more the chances of being susceptible to cardiac disease. So stress number one. Number two, we don't apply to have our minds. Now our brains are getting sort of outsourced. AI is the big boss. As Yash said, I recollect Yash in 1988, I think he was the tutor to Dr. Anjaria, which unit I took over eventually. But what you emphasize most important is the diastolic function. Earlier we used to talk only of systolic LVH and whatnot, but diastolic dysfunction because of the coronary filling is so important. So that was the second thing. Let not AI conquer you all through. And third, of course, LSM, lifestyle, is extremely important in relation to not only patients, but what we often say that physician, heal thyself. We preach to others, but we don't follow it ourselves in practice. So these are the 2-3 important lessons I just wanted to share with you. No pearl and no wisdom. And of course, the last thing, she introduced to me as Pitama, Bhishma and Pitama and whatnot. Once it happened in JJ Hospital that I was going for a program I was about to inaugurate, and then somebody again introduced to me, just like she did, that Dr. Yevlekar is the Bhishma Pitama of medicine. And I told him, I don't want to lie down on the bed of arrows. So, before you tell somebody Pitama, it's fine, it is laudatory, but then what comes in front of my mind, knowing the Indian mythology too well, that on the bed of arrows and all that. And last thing, IKS, I don't know how many of you know that. That is something worth exploring. I did that after the post-COVID era, and I found it very fruitful because I started exploring into that, and that is termed as Indian knowledge systems. Because we studied psychiatry from Freud onwards, we studied sociology from Augustine and onwards. But before that, what happened? So Indian knowledge system, I must tell you, is a treasure house of knowledge, and civilizational knowledge is extremely important in day-to-day dealings with others. It can mold us in a very effective way. So those who get time, at least peep into that. If you get interested, you can go into details. Thank you very much.
I would request our HOD sir to please thank sir with the floral bouquet. I would call upon a nephrologist par excellence. Doesn't need any introduction, Dr. Alan Almeida, sir.
Good evening, all friends, those whom I know and those whom I don't, but they're all friends. Smriti sent me a message saying that I would be wanted to be speaking a few pearls of wisdom. Dr. Yevlekar, my good friend, has already said, I don't know whether they'll be pearls or wisdom, but we'll listen to it. I would have started this talk with how I nearly missed out on being an alumnus of the SAGS Medical College, but that's for another day. In GS, I learned how to hone my skills and acquire knowledge which served me in the life ahead. It gave me, GS gave me memories. Good friend Tushar is here. He's 1 year my senior. The friends for life and much more. But coming to this pearls of wisdom, because I know Smriti has got a cane to put me in line, uh, I learned along the way that we need to learn from each other. It's okay, older doctors are blessed with the experience, the knowledge, and wisdom, and how to discern. But that doesn't mean that the younger doctors don't contribute. In fact, they bring vitality, fresh perspectives, and a techno savvy approach to healthcare. Another thing which I learned along the way is humility and understanding that learning is lifelong, and that even though we have expertise spanning several years, our proficiency is but a drop in the ocean of knowledge. Whilst healing a patient, when we get a successful outcome, you can see it in the face of the patient and the family. But sometimes, though this truly fulfilling experience does not come to us, we have seen that even though we have strived relentlessly, saving a life may not always be possible. Another thing which you need to know, that you can't save everyone. You also need to tend to the heart, which is a key part of the job. Give time to patients, greet them warmly, and recognize that the person beneath the hospital gown is imperative. Finally, our role as doctors is not only to extend life, but to help patients find meaning in life even when their health deteriorates. A few words, I don't know if it's a wisdom, but I think that what we as those who are the medical students or already those who are walking on the road which I have walked, may your practice be distinguished, may your presence be compassionate, may your positivity be a beacon of hope, and may your patients always find in you not just a doctor, but a healer. Thank you.
Thank you, sir. Humility personified. Well, I now would like to call upon an esteemed rheumatologist, and I guess one of the pioneers holding the female gender's flag here, a stalwart, Dr. Rohini Samant, ma'am.
So, a very good afternoon, or is it evening already? So, I think what Milind told me was not pearls of wisdom, and I don't think I have too many of them. He said, talk about nostalgia. So, I think I'm going to talk about that. And I would like to thank Milind for this opportunity because it gave me a chance to revisit all the old memories, which are really ancient looking at all of you. And so you get a slice of what happened in the early 80s. And also to express my gratitude to KEM, this great institution, which really has been the foundation for all that we have done in future. So, most of you actually wouldn't know me at all, I think, because I left KEM about 38 years ago. So, after which I spent 12 years at Nair, and presently, last 25 years, I am at Hinduja Hospital. But I would like to say that KEM never left me, and that longing for KEM and the feeling of belonging to KEM has always stayed with me. So, Milind said that briefly talk for 2 minutes. I start with my residency, which I started with Dr. G.H. Tilve, if any of you have heard about him. So Dr. Tilve was the one who started the rheumatology as well as the nuclear medicine department in this hospital. So he was a pioneer of these two departments. And he was the most benevolent head of unit I have ever come across. So it was it was a pleasurable shock to find that your boss was so sweet. But believe me, the first 6 months of my residency, I spent in the shadow of a very, very ferocious registrar. Who it was, and so much that there were copious tears every day, both the housemen. So I cannot forget my first post or first residency. However, looking back, I feel that he was the one who probably made us learn how to fend for ourselves. So everything, most of the thing was self-learning, and more so, the neighboring unit registrar, it was Bharat Dalvi in the male ward, it was Manoj Chadha also in the male ward, and Dr. Gharpure. Most of you don't know Dr. Gharpure. The kindest soul was Dr. Gharpure, who helped us with all our problems when our registrar was non-existent. So that was for the first post. Now, I had not done enough to get into neurology, which I think most of the people with the higher marks got. And I was with Dr. V.N. Acharya. She was head of the department. So she decided to post me in different specialities, and I think that was the best thing that happened to me. I was posted in gastroenterology, in MICU, and also in the nephrology unit of Madam. So I got a more wholesome experience, I think, rather than just doing neurology. In gastroenterology, I worked with, or rather I was in the unit of Dr. S.R. Naik. Again, most of you probably don't know, but a very brilliant teacher from SGPGI, right? And of course with Dr. Alan Almeida, Dr. Bharat Shah in the nephrology unit. Now, Dr. V.N. Acharya, she was the head of the Department of Medicine as well as head of nephrology. And she truly instilled fear in the minds of almost all the residents, but even more than that, her immediate subordinates. And it was quite embarrassing to watch her subordinates being completely grilled by her as the juniors stood on. So that was an experience in itself. But I would say that such was her charisma, Dr. V.N. Acharya, that KEM actually has a lot of firsts. I don't think Alan spoke about them. I think the first cadaver transplant was done at KEM in 1965. So KEM has a lot of firsts in the Department of Nephrology. And just on the lighter side, I think that was the only department which stayed on till 6 p.m. in the evening, after the lab reports came in, mind you, checking them, discussing them, and then acting upon them. So I think it's an impossible act to follow. I don't think any department lecturers stay on beyond, is it 2 now? Or so then the teaching sessions at KM, I remember, Dr. Anjaria, he used to conduct those sessions. And being an honorary, he used to bring a different kind of wisdom. And we had several honorees, including Dr. Medhekar, who's here. And I remember Dr. C.P. Dalvi because he used to regale us with stories of Meena Kumari and her heart problems. So, in fact, most of the Bollywood stars went to him. So it was quite interesting to attend his clinic. And I was deficient in my neurology, but somehow Dr. Chetan Bhatt, who used to take neurology classes, he made up for most of it, and I could give my neuro long case with a bit of confidence. Now, lastly, a few words about MICU, where I worked almost for 9 months. And initially as a houseman and later as a registrar. So I can still see Dr. Dastur with a very stern expression on his face, and he would actually be, admonishing all the residents about hand washing. Now, it seems like a small thing, but I think this was one thing which he hammered into every resident who was in his unit. And it's really one of the most important things in the ICU. And also, not to forget, Dr. Dilip Karnad, I don't see him here, but he was the one who actually was there in the MICU right from its inception. I was the first houseman, he was the first registrar, and then later lecturer. And he really nurtured it like a little baby. So, and you can see what, now I think what it has grown into. So we learned to actually wash the bird's ventilator. We used to wash it, we used to put it in Sidex, and then we would assemble it. And slowly, over a lot of hiccups, we learned actually how to use the bird's ventilator effectively. So that was a big learning curve at that time. And not through his words, because he spoke very little, but through his actions, we imbibed the ABC of intensive care. So there are many more memories, Milind, but I will stop here. I can see that people are getting restless. And I will conclude with a paraphrased couplet from Mirza Ghalib, which says, हैं और भी इस दुनिया में अस्पताल बहुत अच्छे, हैं और भी इस दुनिया में अस्पताल बहुत अच्छे, कहते हैं कि केएम का है अंदाज़े बयां और
The next stalwart amongst us is our ex-HOD, who is almost like a father figure to me, Sir Dr. A.R. Pazare.
Good afternoon. I think a lot of my PGs are there. My seniors, colleagues, and PGs. I think there are no more PGs now, they are all consultants now, and super specialists basically. I joined KM Hospital in 1999, and I was from a small town, and get to the KM Hospital was a great thing for me. The KM gave me very good thing for my academic career and administrations. But what I started in 1999 was first HIV clinic. HIV was just coming up that. And at that time, drugs were very expensive, and we does a lot of experiments. Along with the Kavita was there, then Smriti was there. And we used to sit from the 2 o'clock to 6 o'clock with a few drugs and ask the companies to sit to give the concessional rate and various combination. We give the combination like chloroquine at that time. And then Sequinavir, I don't think we have used Sequinavir any time. So very bad drugs, so we use that. So double combination, triple combination, we have a lot of combination. Ultimately, we manage the patient and get some funds from the social workers and we manage. And then 2005, get an ART clinic. So for 5 years, we managed this without government aid, we managed ART clinic. What I achieved in this 19 years by KM Hospital, I got a lot of families. You are all my families, and I got so much of love from you. Of course, I scolded you sometimes, but for better you. The PG activity might be that I scolded a lot of people, but that scolded you. Now you are much wiser. I don't think you are one person wise. Much wiser than me. You are all consultant now, nephrologists, neurologists, and all consultant. And you are doing better. I think everyone doing better in their all practice and this consultation. Only one thing I pulse of wise may be the treat patient as your own colleagues or own relatives. Put the hand on the shoulder of the patient, they feel better. And have a empathy for the patient. That's my advice. Thank you very much.
Thank you, sir. So now I would like to call upon one of the most popular teachers amongst undergraduate and postgraduates. And I'm sure all residents will echo that feeling with me. Karnik sir.
Yevlekar sir, Medekar sir, our dean, who's our batchmate, Milind, thanks a lot for this chance. I'll take you back to 1979 when I took admission here. And during my first medicine posting, I saw Dr. Dastur taking, he suspected there was no ultrasound or only one ultrasound machine. For a patient of suspected renal abscess, he took him near the window and he was showing the residents the fullness in the lumbar region and he pointed out the tenderness. Dr. P.D. Anjaria's clinics, where everything from degenerative, heredofamilial, inflammatory, demyelinating, everything used to be discussed on that case, and he used to test the concepts of the candidate. I saw as a student Dr. Medekar in a suspected porphyria case quietly telling the relative, hey, urine घेऊन जाऊन उन्हामध्ये बस. Or a suspected case of myotonia, he made him put his hand in the fridge and the myotonia was precipitated. In one of our GI clinics, Dr. Ravi Barpat on the slide, he used to get a case and to test us. So he bought a case of a young 22-year-old boy with a huge abdominal lump, a liver filling the entire abdomen. And every one of us gave different diagnosis. Dr. Philip Abram quietly opened his pant, palpated, one testis was absent and the diagnosis was there. So what I want to say is clinical science rule. And all these teachers who have taught us, we imbibe their characters, their traits, and we pass it on to our students. I had the fortune of being with Yevlekar sir. Very fast rounds, post-emergency, I used to present the cases to him. 40 patients used to be over in 50 minutes. What I used to learn, extremely dignified boss. Even if he did not agree with what I had started, he used to quietly suggest, Karnik, zara he baga, he add karun baga. That was the hint that probably what I had started was not right, it should be changed. So this dignity, which, he made me imbibe. So you have to teach you, accept your juniors with their shortcomings and treat them with respect. So the point I am making is, PD Anjaria will never go away. Medekar sir would have retired, but he would never go away. They live through us. We live through our generations because and that is the greatness of this institution. I remember me and Sangeeta were posted at Cooper, Dr. A.K. Joshi. We were a bit, sad at heart that wo abhi udhar jaake ek saal post karna hai. And our first day on the rounds, Dr. A.K. Joshi asked me, new boss, new place, Karnik, what is the neurohumoral axis of CCF? I'm looking at Sangeeta, Sangeeta is looking at sir, I don't know. Are you've not read Annals of Internal Medicine? I will get it. So for the next 1 year, if you remember, he used to get his NE James, his Annals of Internal Medicine, mark out the articles, and only instruction was you have to stand. I will not allow you to read. You stand and give a gist of that. Believe me, our first MD paper, first question, discuss the neurohumoral axis of CCF. So this is the greatness of our teachers. And I feel, going back, this institution, this KEM hospital is a legend. I've seen the most average of my students. We've struggled with them. In the first year, they want to leave. You get them back. But the most average of the students by the end of the second year and by the time they pass, they are brilliant. They've all done super specialty. Now they are the kings in their own world. So I think that is my thing. This institution is great. The teachers live through us and the teachers will never die, never go away. Their souls are in this place and they live. Thank you so much.
Well, there is a name which is coming again and again and again. And I'm sure what I'm going to say is Dr. Dilip Karnad. He has said that he's very sorry that he's not able to attend, but he has shared a video message of him, and we are going to play that for you all. Yeah. Shraddha, I'll need your help.
It'll collapse.
This is Dr. Dilip Karnat. I'm very sorry I was not able to attend this very nostalgic event and meet all of you in person. As I read all the messages on the Centenary Celebration WhatsApp group, my mind went back to the days when I walked into GS Medical College for the first time as an MBBS student in 1976. I was confused, scared, and uncertain of the future. That was also the 50th year of GS Medical College and KEM Hospital. By the time I completed my medicine residency at KEM, I was a changed person. At KEM, the volume and variety of patients ensured that you got to see everything that was written in the textbooks. Brilliant teachers ensured that we received excellent clinical training. Apart from academics, college days also introduced me to extracurricular activities, including many outdoor sports that included trekking. Some of you may remember the treks we did years ago. In fact, just last year, my friend Dr. Avinash Suppe and I went on a trekking holiday in Iceland with a former student who is now a distinguished professor of radiology in the US. After completing MD, I stayed on and worked at KEM Hospital from 1984, initially as a lecturer, then associate professor, and then professor in medicine department till 2009. During these years, I learnt a great deal from teachers, wonderful colleagues, and also from my excellent students and residents. We kept each other on our toes all the time with our academic and clinical questions. Today, it gives me great pride to see that many of my students and residents have achieved great heights in their professional and personal life. I thank all of you who have shaped my career and wish you all the best. Thank you.
We now move from reflection to dialogue, from memory to discussion. Residency is not just training, it's actually transformation. So I now move to the panel discussion on medicine residency, my PG days. I would like to call upon Professor Archana Sonavale, Madam, our moderator for the same, to take over.
Good evening, everybody. And hello and a warm welcome to all of you. And I'm Dr. Archana Sonavale. For those who don't know, I'm a professor of medicine and a head of a unit. And today, I'm going to take you down the memory lane to remember your PG days. And to do this, I have with us 5 panelists from 5 different decades of who have done residency during 5 different decades in the last, starting from the 70s. So to start with, we have our first panelist who needs no introduction. He was the professor of medicine for the last 27 years, and he still lives in our hearts of every student who learned from him. His post-emergency rounds used to be legendary, and his bedside clinics used to be scary and wonderful. And I'm sure we have learned a lot. Many of us have learned from him, and those who have will not forget a single word of what he has taught in the past. I welcome to the dais the living legend, Dr. Tushar Medekar. Our next panelist is not only a physician, but she is a scientist. She is currently the director and scientist of ICMR, the National Institute of Immunohematology, Mumbai, and also the Hemoglobinopathy Center at Chandrapur. I call upon the dais Dr. Manisha Madkaikar. Our third panelist, Dr. Anita Matthew, is not only a physician but also a pediatrician. She has done her pediatrics, and after that she did her MD medicine, and she is an infectious disease specialist. She is a senior director and senior infectious disease consultant at the Fortis Hospital, Mulund, and also an honorary consultant at Sion Hospital. Welcome, Dr. Anita Matthew. Our next panelist is unique in the sense that he is the first DM rheumatologist in Mumbai. Dr. Nilesh Nolkha, who has also been helpful to Dr. Seema Kinney in starting the first DM rheumatology at Nair Hospital, and at present he holds the position of HOD and senior consultant rheumatologist at Nair Hospital. And last but not the least, a very ardent teacher who is loved by his UG students and they don't miss a single clinic taken by him. He is a PG and a DM nephrologist from KEM, Dr. Nikhil Rao. Welcome everybody. Hello. Yeah. So, so starting with our first panelist, sir, our generation is really grateful to have a fantastic clinician like you, and all those who have learned from you will be really thankful that they could do residency with you, sir. Your one-liners are legendary, and to quote a few, I think they have been getting quoted today in the WhatsApp group throughout the day. Sir.
Some cannot be spoken of.
But I can speak of one, like when the registrar presented the round, he said that so this is a case of hemiparesis. Sir said, that even Bandu the ward boy can tell. So sir, so to go to the first question, we want to go back down the memory lane to your residency days, sir. How was your typical day during your residency in KEM?
Okay. First of all, thank you all for coming and listening to an old man who has nostalgic memories of this place. In fact, any opportunity I get to come to my second mother, my alma mater, KEM Hospital has made me what I am today. So I am obliged to this institution. I became a resident somewhere in 75, and at that time things were very different. I think the first post which I did was with a person who was having a huge personality, Dr. K.G. Nair. He had just come from the US after being a professor of medicine in US. And he came back to India, and being in the first 4 or 5 ranker, I was his houseman. So I remember a case which came. It was actually a family of 4, 5 who got admitted with vomiting and diarrhea after eating some fish. And later on in the ward, they developed some difficulty in swallowing. So a clinical diagnosis of botulism was made by me. So he came to the round and he said that, how have you proved? So I said, in those days, there was nothing. We had nothing to prove it. So what are you doing for treatment? So I said, basically the treatment was anti-botulism antitoxin, but which was also not available. So what is the next best? So I said, guanidine. So have you procured it? So I said, well, I wrote down to the relatives, and they have gone all around the town, and nobody's heard of this guanidine. He So you have not given it? So I said, I mean, obviously not, I don't have it. So then he looked, he was a person who had lot of registrars and housemen, lecturers, sisterins, and everybody is there. The big looked at me. Look at this man. He is like the Rome is burning, and here is Nero standing with his fiddle. I mean, what am I supposed to do? So immediately he went out in a huff and came back after 5-10 minutes. I think he must have made some 4-5 calls. So he came back and he said, just go down, there is a car waiting for you. So I was pushed into that car, and that car took me to Bhabha Atomic Research Center, where after going around 2-3 departments, I got a jar of guanidine. So by the time it was 3:30, 4 o'clock, with the jar in my hand, this time I was like Julius Caesar, I won the war. So I entered his cabin and he said, sir, guanidine. Bloody hell, what have I got to do with guanidine? Push it down their throats. So we had I have been trained by such professors that it was almost, impossible for you to believe. I can tell you, I can go on. The next post which I did was, I don't know, some of you might have worked under him, was a neurologist, Dr. V.P. Monkar. A neurologist par excellence. He was absolutely fantastic clinical neurologist. But as a man, my God, a terror. Now he had this protocol that every Thursday grand rounds and every Wednesday you have to see the same patient again in the ward, take the entire history, write all the findings again. In those days I didn't understand why it was, but now I know that how neurological processes evolve and how we can come to a diagnosis. So it was at that time that I realized that this is important. Now one particular day, Wednesday I remember, we had 2 or 3 new admissions, and it took me nearly almost 12:30 in the night to finish off those clerking. And then I had to go around, and so at that time, there's a small boy called Atiq Ahmad. I don't know how much of you have seen. Atiq Ahmad was a prize case for VPM. He had gone round the town, no diagnosis, and literally in 2 minutes, when I was his houseman, he said, this is Wilson's. And he diagnosed it in 2 minutes. Therefore, it was his prize case. And he used to be a permanent resident of, Sangeeta will be a permanent resident of Ward 10. So he's there. I never even thought of doing he used to occupy a bed. Now, VPM comes. He had that uncanny sixth sense. He walked into it. He went around over 2-3. And when it was the time of Atiq's bed, he stood there. Yes, doctor, have you examined him last night? You have the lal patti, you have the sisters, you have the houseman, the lecturer, everybody there. No way to say no. Yes, sir. So, he knew I have not done it. So, he had this uncanny attitude, uncanny ability to manufacture clinical science. He didn't have an extensor planter. But in front of, tell me what did he got? He got extensor planter. So, again, doctor, have you examined him last night? Yes, sir. Atiq Ahmad. Atiq को पूछा, ये डॉक्टर ने कल आपको एग्जामिन किया है? Poor fellow Atiq, On one side is his boss who has diagnosed him and treating him. On the other side is his young fellow who has been his friend. He doesn't know what to do. Suddenly, out of the blue and savior, a voice shouts from the entrance of Ward 10, Vasudev. His name was Vasudev Mondkar. She was also an honorary from this hospital. She was Pilu Bharucha. She was the pediatrician wife of E.P. Bharucha, the father of neurology, which this hallowed institution has produced. One of the world's most famous neurologists, E.P. Bharucha, his wife. She was a totally unkempt lady, used to come in all wrinkled saris, but for Mondkar, she was the only terror. The moment he heard Vasudev, he just went away. And I remembered that I am finished. Sorry, I'm coming in the way.
We would love to hear you, sir.
So, this hospital, this institution, which has made me what I am today, is full of lots of things. And I can just put 3 H's to it. Hard work, a lot of history, and lot of hours of clinical and non-clinical experiences. I would definitely like to tell non-clinical experiences a little later. Somebody has to speak.
Let's go on to our next panelist, Dr. Manisha Madkekar. You have changed your path from being a clinician to a scientist. Do you miss clinical medicine? And what kind of avenues are open for the present generation of physicians in research?
Okay. At the outset, sincere thanks to you and the entire medicine team for giving me this opportunity. I don't know whether I deserve to sit here and be talking to you all, but it is a great honor and a very nostalgic moment for me. I did my UG, PG, and I've been in the campus for more than 35 years. I joined in UG in 1988. I think I was interested in hematology. It was Dr. Patare, 2 months allied that I did in my second year in MD. And that decided that I will do clinical hematology as my career. And that time, unfortunately, there was no DM. Only fellowship was there, which was in CMC Vellore. And in CMC Vellore, my parents refused. I said, now you have to get married and you have to be in Mumbai. And Dr. Patare suggested me that I should join IIH. That time it was called as either 13th floor or IIH. So
we know it only as 13th
only
floor.
as 13th floor. So I joined there, I think, initial few years under Dr. Asha and Dr. Farah and Dr. Patare were amazing. I learned a lot of hematology. And I kept thinking that I should move to clinical medicine and Dr. Farah used to always tell me, join lecturer in hematology. Unfortunately, that time there was no permanent position in that. I continued in ICMR. And then after a few years, of course, I got my passion in the area that I really wanted to work, and that was inborn errors of immunity or primary immunodeficiency. And I got to do what I really wanted to do, something different. I think that changed my life. So this is something, and it was really heartening to see Dr. Yash today talking about research. I think it is a responsibility of the institutes like us to develop or to do more authentic research and establish clinical evidence, which then can go into guidelines. And as Dr. Yash has said, why should we follow somebody else's guidelines? It is time that we have our
own Indian guidelines.
But unfortunately, when we sit to write Indian guidelines. We have really limited evidence from India which can actually go into guidelines. So this is time, I think, people should think about research. And I think Dr. Yash has very beautifully said that you don't really need fancy equipments, you don't really need expensive reagents to do clinical research. It is only that mindset, and that mindset is important. And right from the beginning, I think we should inculcate or expose people to research. Now, ICMR, Indian Council of Medical Research, is taking a lot of efforts towards it. It has established
Students are being encouraged to take up research.
Yeah,
Even UG
yeah.
students do, it is sponsored by ICMR.
Medical research units are established now in every teaching medical college, which have scientists which can support research for MD students. Then we have, actually ICMR gives out grants of almost 1200 crores to outside institute, non-ICMR institute. So there is no girth of funds. Now you can have small grants for the beginners, which is up to 2 crores. You have large grants, which is up to 8 crores, and centers of excellence, which is almost 15 crores. So only thing is, we need to develop this culture in the institutes, and it was wonderful to listen to his lecture. I think, I hope it will inspire a few of them. Thank you.
Thank you, Dr. Manisha. My next question is to Dr. Anita Matthew. In the 90s, it was rumored that residents had superhuman stamina. 80 admissions, 100 admissions, the ward used to be overflowing and the patients used to go from the ward through the corridor all the way to the MICU. So, which was the longest continuous duty that you did?
Thanks, Archana, and thank you, Department of Medicine, for having me here. So my first 3 months was in KCP.
Oh.
Okay, so
KCP, you must be in the laundry also for a long time.
Yes. In fact, I went and took my signatures in the laundry. I had to go to Sahyadri to get my signatures there. And I remember that I had one registrar and I was a single houseman and a lecturer. We were just 3 in the department. Of course, Dr. Patel used to come for his quick rounds. That was a saving grace. So we used to have Saturday, Sunday, the whole of Monday. So the minimum that I have done, I'd rather at a stretch in that sense, would be 72 hours. But essentially I was there in the ward 24/7 for those 3 months. I mean, there was hardly any time that you could go back to your room because you were the single houseman.
The residents today should listen to this because we have managed with a single registrar and a single houseman in both the wards. And now we want replacement. Every time, there are 4 or 5 residents in one unit and still they want replacement.
Yeah, so there was no replacement. So even the registrar used to show off by the time it was 12 o'clock. And we used to not have EMS. We used to have an EMR at that time.
Yeah.
So in our EMR, we were the whole and souls. So every single patient who would walk in, we had to go ahead and treat. I mean, and so it used to be, and I had come from medicine, I had come from pediatrics. I had already finished my pediatrics and come into medicine.
I know what you're going to say.
So Dr. Medekar here, when he heard that, he told me that I have come from veterinarian science to medicine. Now you will become a doctor. That was his precise words. And so I tried doing my journey of becoming a doctor during that first 3 months. Was really challenging. So I think all of us in the 90s must have had that particular challenge because we had a lot of lepto and dengue. I mean, hordes of it.
Monsoon used to be
a terror, 120 to 150 admissions. Yeah.
And sir's wit and humor was very famous. When I was a UG and my colleague was presenting a case to sir, she said, this patient is a farmer and he is working in the hot sun every day. Sir said, what, is there anything like a cold sun? So my next question goes to Nilesh. So Nilesh, very important. Which residents troubled you the most for seeing references and how did you make them see the references and take the transfers?
You mean the departments?
Other departments. Other departments.
I think there is no love lost for gynecologists. There is no love lost for them. And I think blessed are those who have spouses as gynecologists. Means I don't understand how a medicine person can marry a gynecologist. He has bitched so much about it. And I have a senior resident now whose husband is a gynecologist. She's post MD and DM rheumatology. And her husband says that you have terrorized the gynecologist so much that those students whom I work with are actually reminiscing of you, that you medicine guys have no heart when it comes to gynecology. And the reason why I say so, I'll just give you an anecdote. What happened is when I was doing my MD, Karnik sir was in ICU. I think we had this MAT-MOD thing started, maternal mortality, somewhere in 2008-9, and you had to go and report things, and the medicine person has to go there. So what happened? Probably Karnik sir or the lecturer had to go to some dean's meeting, and I was the senior registrar of ICU, and the MAT-MOD happened in ICU. So I had to go there. And the MAT-MOD thing start from कब गाड़ी निकली थी, कितने बजे निकली थी, उसका ड्राइवर कौन था, this. So now I am sitting with all the premier gynecologists. The MAT-MOD is going on. I am supposed to give the medicine inputs, and the resident who is speaking is actually my batchmate. So
The gynac resident.
The gynac resident. So the thing starts. The PTINR was 1.19. So the one senior gynecologist says, plasma क्यों नहीं दिया? And for 10 minutes they argued on that plasma. Then I was like, sir, then I had to butt in. I'm like, sir, but I don't think the plasma was required. The IC bleed was probably we did not know what happened. She had a disseminated DIC tha, but that INR on the first day did not justify plasma therapy, and I had to pitch in with that therapy. And I think the second love was for orthopedicians.
Ortho, yes.
And as I think somewhere it has come back to haunt me because I am a rheumatologist.
Now orthos are haunting you all your life.
Yes, so I remember that they were like, operate to karna hi chahiye boss. Operate to karenge. Or
Do you think they used to fake all the investigations?
I cannot say
I am
that.
sure they must be doing that.
I was
किधर से तो create करते थे सब
I was an intern in an ortho department, and I don't want to speak on what happened. So, but I remember a 94-year-old patient being operated despite the relatives saying ki we don't want to operate. I don't know. I still don't remember how they managed to operate.
There are reels showing how an ortho resident takes a consent.
Immediately,
He just signs it himself.
2 hours after the surgery, the patient was in EMS. And I had a hard time because this guy was some big shot known to some politician right across the Shiv Sena branch. And I'm like, that was the nightmarish day of my EMS.
Thank you, Nikhil. And thank you, Nilesh. Sorry. And the next question goes to Nikhil. Also a very important question. How did you dodge the mamas who came behind you with the call book on emergency day?
First of all, I thank the department and thank ma'am for having me be a part of this panel. So being on call was a very difficult task when you had your own admissions. You had 70 to 80 patients in the ward. You would be on call for routine calls on your OPD day and on your emergency days for emergency calls. A very hectic task to see all calls when you already have your own patients, but I found that the system did the work for me. There were multiple roadblocks which ensured that I was not being made to see the call. So the first roadblock was that for a non-medicine resident to understand who is on call, it normally takes a year. And by the time his junior comes and then the cycle follows. There is an emergency on call, there is a routine on call, there's a male ward on call, a female ward on call, and no one knows who is on call on Sunday. If there was a resident who was smart enough to understand this within 1 year, and he did send a call, the second obstacle was this system which is still in place despite this being the age of AI, WhatsApp, up to date, This is our call book. Where a resident has to write the call in duplicate, a mama has to take it, the mama has to reach me before 4 o'clock on working days and before 11 o'clock. No.
Send routine call.
Send routine calls. So, and sometimes the mama would know me, and there was a time where a mama didn't know me and he did catch me before 4, but I wrote my own name and number and said, ye idhar nahi hai. So this was the second obstacle which helped me. If the call did reach me and I did go and see the call, and if the patient was even a little unstable, I would say, "Arey, ये तो emergency call है, ये तो emergency call है. मैं routine on call नहीं देखूंगा, emergency on call देखेगा." The resident would take the patient to emergency. The emergency would stabilize and say, "ये तो routine call है. कल routine call भेज दो." Again, I am spared because not my OPD day. And lastly,
ज़्यादा reveal मत कर.
I hope there are no. And lastly,
Madam भी बैठे.
And lastly, and lastly, if I would go to see the patient and the patient was stable, I would search through all the old files. And there would be an old OPD paper. I would tell them, "अरे ये तो हमारा patient ही नहीं है, old case किसी और का है." So even if 50 people wanted to send me the call, I would end up seeing only 5 calls. So I did this for 6 months. Unfortunately, after that, my then girlfriend and now wife, who is now in the hall, she joined surgery. And from then on, I was on call 24/7 for the entire surgery department. So yeah.
Great. That was amazing. Surgery se sabe.
His next worst thing to gynecologist being married.
The next question is to Medeka sir, and this is actually a serious one. Sir, the PG selection process during your time and even our time till Kavita and me were there was based on the MBBS marks, and that's why students used to take their exams very seriously. And now it is just that one MCQ based, NEET rank based. So has this changed the profile of the residents? And compared to the residents of the 70s and today's residents, what do you think we have gained and lost?
I think we have gained only one, that the books of MCQs, they are hotcakes, you know. I came to know this somewhere around maybe early 90s, when I found that in my class, which I used to take for the postgraduates and the undergraduates, from Nair, from Sayan, from JJ, people used to attend. And I found out that forget about Nair, Sayan, JJ, my own people are not there. So 2-3 people were there. So आप उनसे पूछ कि where are they? तो बोलते वो रट्टा मार रहे हैं. रट्टा मार रहे हैं ये क्या होता है? तो it seems because they have to go through these various needs, though they have to know this MCQs and know it so well that as soon as they read the first part of the stem, they know the answer. This is what has happened after all this. The second thing which I realized was, I remember somewhere around the 70s, little later, when first time the people, the medical fraternity started going towards instrumentation and more of investigative medicine. So I remember I started my round and one registrar started, "Sir, this is the case of fever. Urine routine is showing 40 to 50 pus cells." I said, he was my student. So I said, "If you do this again, I will not sign your thesis." So poor fellow, then he realized that what is the importance of examining the patient, coming to a clinical diagnosis, and then using just those investigations which will prove your diagnosis. And this is still what I'm teaching at some of the DNB students which are there in Lilavati, that your diagnosis should be ready at the end of history. History gives you diagnosis by almost 90-95%. The physical examination confirms it, and investigations are to be asked only for confirming your diagnosis. I make it compulsory for them to write down. You may be wrong, but if your reasoning is right and you come to a diagnosis, it is still a very, very important aspect of the whole thing. By doing more investigations are not only spending more money, but you are also subjecting patients to multiple problems, and the diagnosis gets unnecessarily delayed. So this thing is that learn clinical, and that is why whoever is here, these 2 years which you have got are the most important years in your life. My success I owe to those 2 years I was houseman registrar in this institution. Nothing else has helped me more than that. What I learned in those days is something phenomenal. I'll just give you an example. I still remember a patient who had come with a history of fever and abdominal pain right side. There was no ultrasound. We had only plain X-ray. And the only clinical sign was absence of tidal percussion. On the basis of that, I told my Dr. Anjaria that, sir, this is amoebic abscess. You know what he said? What are you waiting? Dalo na needle. And believe me, without ultrasound, without anything, we put in a needle and 250 cc's of anchovy sauce came out. So this is what is clinical medicine. It is what we learned in those days and which still I follow. I tell the patient that sir, CT scan, sir, MRI. Arey Baba, nahi jarurat. You just do one ultrasound, your diagnosis will be there. And that is where you should be finally be. Because ultimately, investigative modalities will increase. This is because electronics is going to go by AI. And it will just go leaps and bounds. But I still believe that the best computer, the best AI will never ever replace a well-experienced and a knowledgeable clinician, ever.
Thank you, sir. And I remember when I was a PG in your unit and somebody was hesitating to make a diagnosis, you said, "Arey bol na, you will not be put on a guillotine." Then first I went and saw what is guillotine. And then I understood. So, for the next question, Anita, in your residency, could a resident have corrected a faculty in front of others? And what would have happened if they tried to do it?
So I had my residency with two units which were predominant. One was Dr. Karnad and the other was Dr. Chiklekar and Dr. Medekar's unit. I think correcting them was not an option. It was a non-option.
That was not needed only.
Yeah, it was not needed. And there was not, Dr. Chiklekar used to take his rounds on Wednesday, which was our post-emerge day. And Dr. Medekar sir used to take it on Saturdays. His Saturday rounds used to start at 7:30 in the morning. So essentially every time we used to make a fool of ourselves, any which ways. So we used to start reading the whole night and we would come prepared and we would look as if we have hardly slept. So sir used to say, sabko bahar nikalo. All the relatives should be out of the ward. It used to be patient and one relative and the doors were locked. So whatever used to happen, it used to be. behind the doors, closed doors. At least the good part was we used to not lose face too much in front of the patient's relative. So there was no question of correcting. So.
Thank you, Anita. And Nilesh, what were the condition of the RMO quarters and how did you cope up with that?
It was not great, but we somehow managed. We never stayed in the quarters, to be precise, because I think if you remember, ours was the batch where the FCPS had been abolished.
Okay.
So instead of 20 residents, we were only 9 registrars. And I remember in February, we pleading with the whole department that if you don't give us a leave now, we will exactly fail. Because probably after us, there were 24 residents per batch. So
Yours was the last batch with 10 registered.
yeah, so we hardly stayed in the quarters. Sandeep here was my batchmate. We used to go out at 7:30 in the morning and maybe catch a nap in the afternoon, but directly at 11 or 12, we used to have 1 million ka coffee and read whatever we could read in those days. So we survived with 9 students, 9 registrars. That was, and not before and not after, maybe somewhere in 80s, but we were the batch with the least amount of registrars in recent past, yeah.
Now we have a problem of plenty. We have 23, but still they are like,
So immediately after we passed out, the intake was per student. They started taking 2. Yeah.
Per
professor, yeah, they
now
started
it's
taking
3.
2.
So that brings us to the, when you said we hardly stayed in the hostel, I thought you stayed in a flat or something.
No.
In the ward only, ward side room.
Yes, what? We used to carry toothpaste and brushes, and because for us the emergency so when I entered as a houseman, the emergency was run as a separate unit. So you get an emergency.
It was always like that.
No, but
OPD unit
during
and emergency.
my registrarship, I used to handle both EMS and both wards. So Sanath is here. Sanath used to handle. So one male houseman used to be in the male ward. The female houseman and me used to be in the EMS. So we were the only batch in that time who used to handle EMS and wards both at that time. So we actually, even in my registrarship, we did not go to rooms.
So so you didn't need the rooms, but the present residents need rooms, and many of them don't have. So they, I think some of them take flats, etc.
No, we were less in numbers, so that was not a problem.
That brings us to this graph for Nikhil. So from pocket money to pocket lint. Lint, I hope you all understand what is lint. Nikhil, can you see it here?
Yes.
So the question is that who was really richer? I feel like the people in the 90s were richer, because if you compare the inflation, then what, even though we feel that the residents today are earning 85,000, लेकिन inflation कितना है? Rent कितना ज़्यादा है? और इधर hostel मिलता नहीं है, rent है, then there are so many things to buy, plus social media pressurizes you to buy many things. So who was better off, do you feel?
So I have a very different perspective to this question. So I remember right from MBBS and probably before that, we were always told that if you want to become very rich, don't become a doctor. And that has translated somewhat into a feeling of almost guilt at wanting to earn a lot of money.
That should not be there.
So, but it is there, ma'am. Definitely it is there. Coming to someone who is in his mid to late 20s, who's doing residency, probably super speciality after that, you're going to be earning around 80,000, and if you want to live outside, rent around Parel costs, it's anywhere between 20 to 30, 35,000. On top of that, food and other basic amenities. You end up saving probably 20 to 30,000 a month, which is not much for your 20s and probably even early 30s. And this is not even taking into account that some of the residents might be supporting families, their parents, their wives, partners. And considering all this, I think, and anytime we want to ask for more money for a stipend hike, it comes out as in a very disgraceful way. For example, if we have strikes, and even if the strike has been for some other reason, like security, but if one of the demands is a pay hike, it's always portrayed as if doctors are hiking or are striking for money, which I don't think should be the case. residents, even faculty, believe should support each other, and all of us should have a pay hike because we are doing more work than what we are getting paid off, and there is no shame in asking for not money, not more money, asking for money which we need. Yeah.
Actually, I have at least another 10, 12 questions, but Smriti is looking at me very angrily. So I'm just going to ask each one of the panelists to give a take-home message. So, sir, one word or one sentence of advice to the current first-year residents who are sitting in the audience today. Sir, all of them are sitting there. At the back.
Oh. Okay. Yeah. I would still repeat the same, that this is the only time in your life that you will learn clinical medicine. Please utilize whatever time you get in this institution as a resident to learn as much as possible, see as many cases as possible. This hospital has a variety of cases which I have not seen anywhere in the world. When I was in England training, they asked me that, how is it that you are so good in your clinical? So I said that it is just because of my training. So he said, training is where? I said, in KEM. So King Edward means they're little, apna Raja. So, apna Raja means they felt, very good, very good. So I said, do you know KEM hospital? Official beds are 2,500. Unofficially, we used to treat 10,000. So he said, 10,000? I said, yes. One patient, below him another patient, side one patient, here one patient, another patient.
Bed sharing is one bed.
I mean, the dean herself is saying that one. So the degree of
Bed sharing.
bed.
We take consent. They don't understand this.
So the degree of pathology that we see is immense, provided you have the willingness to see the pathology. I have somebody who's, I think you were saying, I have not left I was a registrar in the Saturday unit only. And every 6th Saturday, it would be starting from Saturday to Tuesday morning. I will be sleeping for minimum, just a maximum 3 to 4 hours. Continuous patients are coming. Continuously they have to be. After this, my boss comes. There was a patient who was just diarrhea, vomiting. So I said, sir, diarrhea, vomiting. Dr. Injaria, short fellow, someone like our Lal Bahadur Shastri, ex-Prime Minister, छोटी-छोटी चीजें भी कभी-कभी बड़ी काम करते हैं. So he had this old type of stetho, floppy rubber tubes too, and he would bang it onto the patient's this thing. ECG lao. So अभी nausea, vomiting, diarrhea का ECG कौन देखते हैं? Professor, he used to call him, Professor, क्या है? Gastroenteritis, कुछ फ्लैजिल बीजल कुछ चल रहा था. Auscultate. See the ECG and tell me what it is. He had a single second sound. He was mildly sinused. And the ECG was typical of corrected transposition. After the round, from the ward 9 up to honorary's room, till the time I had to go with him, he said, Professor, you should not do this again. A doctor has to remember that however busy you are, you have to give each and every patient equal and good amount of time. And that one thing taught me in life. I never ever spend less time on a patient, even if it looks very, very simple. Because it is these simple cases which finally turned out to be complicated. So I have learned a lot on this institution, and this institution has given me what it is.
Thank you, sir. Dr. Manisha, what is the one value that KM instilled in you that no other institute could have?
As sir has already said, I think it laid down a best foundation that I could have. The experience that you get here in these 3 years of residency is immense, and I think you can take up any challenge. You are ready to take up any challenge in life. I think that is what I think.
Dr. Anita, name one 90s tradition that you would bring back today.
Less of social media and phones.
Perfect. I think, yes, I think that's perfect. Yes, or vada pav. That was a favorite. So, Nilesh, what was your favorite food item from the RMO mess of the Shetty's canteen?
I think vada sambar is what we used to have every morning. Me and Sandeep used to probably end up there. Our RMO canteen was really bad at the night. So central canteen was pretty good, but
I think most of the people in the audience would say Milan ka ban maska. That was something.
that we used to have at night with coffee. Either we used to go to sleep or we used to not sleep at night, depending on when the coffee kicked in. Basically.
Uday Shetty samosa, Punjabi samosa. And Nikhil, one survival hack for the current residents.
One survival hack I would give two. The first is ask for help. There are a lot of people, everyone is there to help. Everyone wants you to do well. It could be in an academic way or a non-academic way, but ask for help when needed and you will receive it. And second is teach.
This is Harry Potter's dialogue, by the way. Help will be given to those who ask for it.
Yes. And second is teach. You could teach your juniors, you could teach MBBS students, anything, but teaching helps you more than it helps the students. So those are two things which would be survival hacks.
So thank you to all the esteemed panelists for their deeply human stories. KEM has always been more than a hospital. It is a training ground, a family for many of us, and a defining chapter of life. And here's to the past that shaped us, the present that challenges us, and the future that will carry forward this legacy. Thank you very much.
I would request our moderator, Dr. Archana Madam, to thank all of the panelists with a small eco-friendly bouquet, which is homegrown. We
सांज ये गोकुळी सावळी सावळी सांज ये गोकुळी सावळी सावळी सांज ये गोकुळी सावळी सावळी सावळ्याची जणू सावली सांज ये गोकुळी सारे जणू होय कान्हा मंदवाऱ्यावरी वाहते बासरी मंदवाऱ्यावरी वाहते बासरी अमृताच्या जणू ओंजळी सांज ये गोकुळी सावळी सावळी सावळ्याची जणू सावली सांज ये गोकुळी सावळी सावळी. थँक्यू.
Attention people, dance performance is incoming. दिल थाम के बैठिए. I'm going to present to you जवा दिलों की धड़कन, जो अपना दिल हथेली पे रखती हैं और रिदम अपने कदमों तले. हमारी एसोसिएट प्रोफेसर डॉक्टर किरण अहीरे.
राई बरेली में तू बीच बाजारी जब हुस्न दिखाने जाएगी, होश उड़ाने वाली शौक नजर के जो पेच लड़ाने जाएगी. राई बरेली में तू बीच बाजारी जब हुस्न दिखाने जाएगी, होश उड़ाने वाली शौक नजर के जो पेच लड़ाने जाएगी. अरे बहन के इतना जेवर गहना, तेज हवा से बच के रहना, गिर जाए तो फिर ना कहना झुमका गिरा रे.
What झुमका? What झुमका? What झुमका?
What झुमका?
first year of residency is the year of shock, shaping, and silent strength. First year. First year. First year. First year of residency is the year of shock, shaping, and silent strength. Between duty hours and learning curves, they still find courage to create. So guys, we now invite our current first year medicine residents to present their dance, a celebration of youthful spirit within the disciplines of medicine. Stage is all yours, guys. Rock it.
अरे ऐसा झटका अरे ऐसा झटका लगे जिया पे पुनर्जन्म हो जाए ओ खई के पान बनारस वाला ओ खई के पान बनारस वाला खुल जाए बंद अकल का ताला ओ खई के पान बनारस वाला खुल जाए बंद अकल का ताला फिर तो ऐसा करे धमाल सीधी कर दे सबकी चाल ओ छोरा गंगा किनारे वाला ओ छोरा गंगा किनारे वाला
गोरी 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 कभी कभी कहीं कहीं चोरी चोरी गोरी 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 कभी कभी कहीं कहीं चोरी चोरी छुप छुप के तुम मिला करो प्यारी प्यारी बातें बातें किया करो पर यूं ना मिलना किसी से कभी हमारे सिवा
Let's start a bit. सर को घुमा ले राउंड पैर सारा अप डाउन कितनी सी ये बात वे वो बनता ही क्या है जो नाचे न गाए हाथ में तू हाथ थाम ले कोई डांस पे चांस मार ले ओ सोनिया डांस पे चांस मार ले ओ बलिया डांस पे चांस मार ले ओ सोनिया
Wow, guys, that energy next level.
Sir is advising they should take tuitions on this from Kiran Madam.
Okay, so the advice from HOD sir is first year residents have to have special tuitions from Kiran Ahire madam. So second year of residency is where the confidence sets in, where hands become steadier, and where one learns to carry responsibility with rhythm. I now invite our second year postgraduate residents to the stage with their dance performance.
देखो देखो है शाम बड़ी दीवानी, धीरे धीरे बन जाए न कोई कहानी। देखो देखो है शाम बड़ी दीवानी, धीरे धीरे बन जाए न कोई कहानी। दिल भर है दिलकश है दिलदार नजारे हैं, आज जमीन पर उतरे कितने सितारे हैं। अगलो होश नमी दानम, हम है दिल है और जानम, बस दीवानगी 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 है। ना कोई रहसन ना रहबर, ये इल्जाम लगे किस पर, बस दीवानगी 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 है। All hot girls put your hands up and say Om Shanti Om. All the cool boys come on make some noise and say Om Shanti
कोई कहे कहता रहे कितना भी हमको दीवाना, कोई कहे कहता रहे कितना भी हमको दीवाना। हम लोगों की ठोकर में है ये जमाना। जब साज है आवाज है फिर किस लिए हिचकिचाना। जब साज है आवाज है फिर किस लिए हिचकिचाना। गाएंगे हम अपने दिलों का तराना। बिगड़े दुनिया बिगड़ने भी दो, झगड़े दुनिया झगड़ने भी दो, लड़े जो दुनिया लड़ने भी दो। हम अपनी धुन में गाओ, दुनिया रूठे रूठने दो, बंधन टूटे टूटने दो, कोई छूटे छूटने दो। ना घबराओ हम है नए, अंदाज क्यों हो पुराना। हम है नए, अंदाज क्यों हो पुराना।
I'm sure all the cardiologists, everybody's having tachycardia here. And for the right reasons. The violin. The violin is perhaps the only instrument that sounds like a human emotion held in wooden silence. And who amongst us we have? We have Dr. Arnav Todgaonkar, who is our ex-alumni medical oncologist, who would be performing a small violin recital.
Good evening, everyone. So, since I have a chance to take the mic in my hand, I am going to take a minute to speak. So, I started learning the violin at the start of my medicine residency, which is possibly, if I'm not playing properly today, you know the reason. I did not get any time to practice. But all my performances so far have been for the Department of Medicine, so it's an honor again to perform here today. And in this beautifully new renovated MLT with so many great stars of the medicine department in the audience. So thank you for having me here today.
Thank you, Anna.
So the song I've selected for today is Edelweiss from The Sound of Music. It's a song full of spirit for the country, for the institute, full of love for everything that has made us what we are today.
कुछ अल्फाज शोर नहीं करते, वो बस दिल में ठहरने के लिए कहे जाते हैं. Poetry doesn't raises its voice, it deepens it. It's my pleasure to invite the very popular Dr. Siddharth Warrior to bring to this evening a gentle close with his poetry recital, Gravity.
Thank you so much for having me. It's an absolute honor to be able to perform here. Before Gravity, there was another poem that I wanted to share because it is tied with my experience in KEM. In my second year, when I did my neurology posting with Rawat ma'am, I saw a case of limbic encephalopathy. And as a medicine resident, I always used to like poetry, but first year में कभी time मिलता नहीं था. And second year में, as you know, rotation में for the first time you taste freedom. And when I read about the limbic system, I felt like I should write a poem on the limbic system. 3 years later, I found that there was a organization called the Hippocrates Poetry Organization, which is specific for medical poetry. And they meet once a year in different parts of the world. And I happened to share this poem with them. And I became the first Indian to be able to go to London and actually perform this poem in front of the world audience. So somewhere I owe that to the inspiration from our neurology department. So I would like to share that poem. It's called Limbic Love. Our limbic system had a complaint to make. Every other system in the body would take all the credit for running the show, and it seemed no one even wanted to know what the limbic system is or does, or how important it is to us. So getting all emotional, as is the limbic way, the limbic system went on strike one day. And no one noticed. It was a busy time of year with membranes to make, metabolites to clear. The heart, pumped up as usual, didn't miss a beat. The ass, like an ass, didn't even get up from its seat. The liver was too busy living to be of much use, and the stomach was too full to digest the news. The lungs wanted a smoke, so they stepped out for air, and the kidneys, well, they were too stoned to care. The cerebral cortex, as always, trying to make sense of every action, its purpose, and its consequence, was so caught up, it took a long while before it realized it had forgotten to smile. The eyes could only watch as memories were made but not felt, and eventually begin to fade. The ears overheard things like excitement, humor, but dismissed them all as passing rumors. And then love happened. And something changed. Those carefully placed jigsaw pieces got rearranged. Thoughts started racing. They would not wait for logical explanations that now seemed inadequate. The body panicked. The cortex tried its best to calm down a heart, now thumping frantic in the chest. To reason with a stomach full of butterflies now. With lungs trying to breathe but had forgotten how. Nothing was working. The mind confessed that I'm losing myself with all these suppressed emotions. So finally, everyone pleaded with the limbic system to come back where it's needed. And come back it did. With a swirl and a flare, because it's limbic, it does everything with a theatrical air. And so love found its purpose, other emotions too, and a famous poem was written to give limbic its due. Thank you.
Fabulous, fabulous. Siddharth at its best, as usual. Love, as he said, just to give you an idea, the Department of Medicine has given 8 people till now their spouses. So we have 8 couples in the house. Okay, so on popular demand, we have our head of the department, Dr. Nadkar sir, Once again for you guys.
To all the residents, when you enter my office, the exact door, the wall exactly opposite that door, there's a frame, and in that frame, there is a poem which is written by Siddharth. So next time, all of you come to my office, please read that poem. Okay? Now. I'm singing this song, which is a dilemma of a young girl who has been proposed by two different men, and she is very confused whom to choose. अरे तू करून दे ना मला मग कन्फ्यूज होता परत. कई बार यूं भी देखा है ये जो मन की सीमा रेखा है, मन तोड़ने लगता है. अनजानी प्यास के पीछे, अनजानी आस के पीछे मन दौड़ने लगता है. कई बार यूं भी देखा है ये जो मन की सीमा रेखा है, मन दौड़ने लगता है. राहों में जीवन की राहों में जो खिले हैं फूल फूल मुस्कुरा के, कौन सा फूल चुरा के रख लूं मन में सजा के. कई बार यूं भी देखा है ये जो मन की सीमा रेखा है, मन तोड़ने लगता है. अनजानी प्यास के पीछे, अनजानी आस के पीछे मन दौड़ने लगता है. जानू ना जानू ना उलझन ये जानू ना, सुलझाऊं कैसे कुछ समझ न पाऊं, किसको मीत बनाऊं, किसकी प्रीत भुलाऊं. कई बार यूं भी देखा है ये जो मन की सीमा रेखा है, मन तोड़ने लगता है. अनजानी प्यास के पीछे, अनजानी आस के पीछे मन दौड़ने लगता है. कई बार यूं भी देखा है ये जो मन की सीमा रेखा है, मन तोड़ने लगता है. अनजानी प्यास के पीछे,
अनजानी आस के पीछे मन दौड़ने लगता है।
So we now come to the end of the formal MLT section of our cultural event. I would like to call upon Dr. Salagre sir to give a formal vote of thanks.
Namaste, Namaskar, good evening. I'm not at all going to take time for this, but I need to tell you a few things which are very important. Last year, the calendar was opened for every department to book the slot. And we were the first one, under the able leadership of Nadkar sir, to book this hall on this day, considering a good winter, a nice, lovely, romantic environment in the Dean's lawn, and also many times, actually international people also do come this time. So 13 December was booked way back, 1 year back. After that, you saw that how the WhatsApp group formed and everybody got actually together. When it was 90th year of KEM, I'm not going to recite a poem at all, but there was a poem which is in Marathi, which I actually did something called as a Vidamban Kavya. Means, those who are knowing about what is Vidamban Kavya, that the tanza remains same, but the meaning is completely contextual. So, there's an appeal in that song that Gaganala Gavashrani Ghaltana Ya Maya Maulila Visru Nakos. I think everybody deserves a round of applause. ही माया माऊली जिला मेढेकर सरांनी त्यांच्या पहिल्या प्रश्नाच्या उत्तरात माऊली म्हणून संबोधलं, याला अर्थ आहे माझ्या मित्रांनो, मेढेकर सरांसारखी व्यक्ती जेव्हा ह्या इन्स्टिट्यूटला माऊली म्हणते आणि मग आपण सगळेजण मान्य कराल की जिंदगी धूप मेडिसिन डिपार्टमेंट घना साया. ह्या बॅकग्राऊंडवर let me sincerely thank our Dean Madam. Since last year, every day there are not only events, but there are events. But with same enthusiasm, same grace, she comes, she participates in each and every function. Last week, she was with me for hypertension services. Every CME she attends and she encourages people. So that's the leadership. And we thank Dean Madam for that. Our former Dean, I had written ex-Dean. Sir corrected me that it is not for ex-Dean, it is former Dean. So our former Dean and Director, Sir, Yavlekar Sir, thank you so much. Our academic Dean, our medical superintendent were here. TP Medekar Sir, my unit, which I was belonging to, Dr. TPM unit, and subsequently, after 8 years of my lecturership, I got that same unit after TPM Sir resigned. And Ameya was my student that time, Ameya Medekar, right? So that is where Medekar Sir, and people are here to listen to him, and we had a gala time listening to the stories of 70s and 80s. Friends, we also have Alan Almeida Sir, we have our former HOD Pazare Sir, Dr. Yash Lokhandwala, who actually inspired us, and all the senior faculty members of our institution. All their photos are on the tree, which is a Vatavruksha, and we have symbolized that. So please visit that tree where I am addressing to all of them. After that, we have faculty and alumni, the students right from 1971 batch. And from 1971 batch till 2025 batch, we have made a placards. When you go to the lawns, your batch placard is there. There is a group photo area there. So please have selfie or the group photo with that placard, which has a heritage look, and post it in the WhatsApp group so that we cherish these memories lifelong. So first round of applause to all those who are here for gracing this occasion from your busy schedule. And actually, we were so touched by seeing your progress. The way you narrated your, Smriti used to give you a task, and used to all, and it is so proud moment for all of us that ultimately teacher's life, what is the earning? This is the earning, isn't it, Farah? That is what we have earned. I think we have earned it, and that is where this institution has actually connected to you, all of you to us. Our SRs and all our PG students, and I think a big round of applause. I'm very humble when I say, and I've not done nothing wrong in that, you know that, till 3:45 a.m. I was here. Because the arrangements were going on. Don't clap. But my PGs first year were practicing from 12 o'clock to 2 o'clock. At 2 o'clock, I came and I just saw them like this. म्हणजे उद्या राहून घ्यायची नाहीये का? They understood. Then they went and slept. Maybe, or they must have gone to the ward. So clap for all of them for such a wonderful performances. All our singers who are here. And there are some names which I have to take quickly now. Our department, and all of you will remember Rane. Chavan madam is here, so thank you all of them. MLT staff, Dhuri and the team is here. We have catering team led by Satish Kanekar, the famous Satish caterer of Dadar is actually catering us. Decoration team led by Shardul. We have a printing team, and all of that thing which you are seeing just now in the lawns is all created by one Ranchod who says, whatever I used to tell him, Saab ho jayega. So that's the positive attitude I learned from him. He just used to say, Saab, aap bolo ho jayega. So that ho jayega, that positivity actually is very infectious. Sound team by Mr. Tambe, and he is going to quickly shift to the lawns, and the event is going to continue. There are very excellent singers here. Pushkar is here. Yeah, Pushkar is here. Shobha is here. I can see Dilakshi. So many of them. Yatin, yeah. Jatin. There's so many of them here, and all of you are going to get mic. Within 5-10 minutes, he will get adjusted. And we are actually going to enjoy with all that togetherness our welcome drinks and starters. And then soon after that, we will obviously start the dinner menu. But what is important is that we need to be also listening to them while we are chit-chatting, enjoying. So that is what is the team. Now, I request all 13 departmental faculty currently, please come down here. All 13 departmental faculty, please come down here immediately. Not here. All 13 departmental faculty currently working, whoever is currently present here, please come down. Because I think this is it's not I'm not giving Thanksgiving. All of us are giving Thanksgiving. And sir, we actually, all of us, thank you for this wonderful evening. I think the connectedness, the love, the affection, which all of you have showered us for years together, let it get continued. And we will be having our 125th reunion with the entire same people around, sir, including you. Yes. So with that, I think there are a couple of important announcements. So we all thank you, but we have elaborate arrangements for our dinner. Everything is there. Immediately the musical thing also will start. There are a couple of selfie points. Our all ex-HODs right from 1926 photographs are there. By the way, we have a graffiti. In that graffiti, please drop a quick message, either maybe a word or a caption, and sign it, so that we will be cherishing that as a memory in our department. We have a stage there for performing, and we have a group and selfie point. Also, a fun element added by Shraddha is there, where in the morning I have posted some secret photo with Munna Bhai, right? So let's chill now, and for the last announcement of what immediate next is here.
Thank you everyone. अगर कुछ ऊपर नीचे हो गया, so please forgive me. That's my registrar speaking there. You rock it, Harshad.
Just before we end, I just want you all to get up and appreciate the efforts that are put in by Dr. Salabhe sir.
Sir, पुढे या. सर्व पुढे घे. सर्व पुढे घे.
Sir, आप
Hello.
of you please join at Dean's Lawn for DJ, dinner and karaoke?